So 3 major themes emerged from this case study. The first is that clinical leadership is central to successful healthcare reform. Clinicians are in an ideal position to identify gaps in care and opportunities for improvement, but they've often in the past lacked a mechanism to implement those interventions. These new payment models offer new opportunities to accomplish these changes to the healthcare system. But success in these new payment models depends critically upon creating value, which is the intersection of both cost and quality. Recognizing that pediatric asthma was an important problem in her community, Dr. Woods in the Boston Children's Hospital developed the Community Asthma Initiative. The idea was simple. Through preventive measures, they could improve outcomes and reduce costs. They introduced community health workers and introduced environmental remediation services, which are services which are not traditionally paid for through the fee-for-service medical system. The CAI has been successful in demonstrating a positive return on investment, and yet it is primarily supported through grant funding and philanthropic mechanisms. And the pathway to sustainability comes through these new payment models, and in particular through bundled payments and shared savings models. In Arkansas, Dr. Thompson described how a new payment system was developed, which was born out of financial crisis. At the heart of this, the Arkansas reforms are a group of providers who are held accountable for outcomes, costs, and the patient experience. Providers in the Arkansas models have a greater ability to innovate and to offer services which directly meet the needs of their unique patient populations. But at the same time, they're held accountable for the costs, the overall costs of the care that they're providing. Physicians have limited experience with these new models, but they offer a tremendous promise to improve healthcare. Yet, at the core of all of these new models is clinical leadership. Clinicians need to identify those opportunities and find ways to implement them and to critically reevaluate how care can be provided. The second major theme is that payers play a critical role in successful healthcare reform. But payers need to create a compelling business case for providers to participate in these new models. Payers cannot realistically expect that large numbers of providers are going to participate in new payment mechanisms if they are likely to lead to losses, financial losses. Conversely, physicians cannot assume that increased funds will increasingly be available to introduce new innovations without being held accountable for the growing costs of healthcare. Assessing the business case for these new payment models is really challenging, in part because some payment is delivered on a fee-for-service basis, while others may be developed, may be paid for through bundled payment mechanisms. And some clinicians will find it really challenging to anticipate how much they're going to be paid and what resources will ultimately be available for their patients. The uncertainty associated with these new payment models also adds to business risk for individual provider entities and hospital facilities. Given this complexities, many physicians may be hesitant to participate if it's on a voluntary basis, just as a job seeker would hesitate to take a position where there's no clear salary. While investment in community health services and environmental remediation can clearly improve outcomes in patients with pediatric asthma, for physicians to make major changes to the way that they're delivering care, especially if those changes require large upfront investments, they will need to have a financial incentive which is sufficiently large to justify those investments. And those incentives have to be very clear. If, as in Massachusetts, you have primary care medical homes where providers get $12.50 per member per month for all patients, and in addition receive a $50 per member per month payment on top for patients who are in a high-risk asthma, have a high-risk asthma diagnosis, there may be sufficient funds to extend the spectrum of care. In Arkansas, if you have an acute care bundle paired with primary care medical homes, which receive majority of their care on a fee-for-service basis and receive an additional $4 per member per month for coordination of services, they may choose instead to better coordinate care with existing public health services. Which of these two approaches is best remains to be determined. The third major theme is that the roots of poorly controlled pediatric asthma reside in the community. As Dr. Keller articulately expressed, the social determinants, socioeconomic factors, largely drive many of the factors which make asthma very difficult to control. These factors include poor quality housing, indoor air pollution, secondhand smoke exposure, and low health literacy. Dr. Woods described the importance of culturally appropriate patient education and environmental remediation in addressing this problem. The healthcare system can address some of these factors, but can't always address all of them. And it's important to recognize that the public health system also has an important role to play here. Healthcare reform has often addressed the medical care system rather than the public health system, but many of these interventions better align with the public health system. The public health system offers a large spectrum of services which are relevant to patients with pediatric asthma, but has not always been well coordinated or easy to access. In addition, the public health system is chronically underfunded and is becoming even more so as medical care expenses continue to grow. There are clearly important public health interventions which can be delivered through the medical care system, but these should not supplant the primary preventive role of the public health system. And my concern is that if we provide too many public health interventions through the medical system, that it will further exaggerate the imbalance between medical spending and public health spending. A strong and adequately funded public health system is necessary to coordinate the different state and federal agencies which are relevant to management of the public health and reduce the risk of pediatric asthma. Selectively paying for some services through the medical system may make sense, particularly because changes to the public health system will take time to develop. Alternatively, coordinating existing public health services through the medical system may be a good alternative. So our case today explored the ways in which payment reform can improve the care of patients with pediatric asthma. Physicians account for or direct the vast majority of healthcare spending and must be part of the solution to improving outcomes and reducing costs. If you're watching this video, or if you are in the room today and you have patients with pediatric asthma and you see gaps in care or opportunities for improvement, new payment models may offer a sustainable funding solution to implement those changes. A practical next step is to identify which of these interventions are most relevant to your specific patient population and to assess the cost and scope of creating these interventions in your patient population. With this information, you'll be in a better position to assess whether or not it makes sense for you to participate in new payment models and potentially also to engage with payers to get resources to implement these new interventions for your patients. Engaging in these new payer models now, or these new payment mechanisms now, even if it's on a small scale, will stand you in good stead in the future as these new payment models become far more widely implemented.